Hi, it's me, Dr. Mohammad Kazafi. You are watching Dr. Mohammad Kazafi Views. Good morning, where there is a good morning. Good evening, where is the evening. I want to present one important case with the detail of some topic, and it is very common and important topic for all of us as a neurosurgeon, which is called the thoracolumbar burst fracture. And the presentation, I want to present one case. This is the 35-year-old male who fell from the height. He complained of the mid and the low back pain as well as numbness along his right anterolateral thigh. Past medical history unremarkable. Exam 5/5. Strength throughout the lower extremities and the no focal weakness. Decreased sensation to light touch on anterolateral right thigh and reflex 2/4 at the patella and the ankle bilaterally, and the perianal sensation intact, rectal tone intact with good violation. As you know, the differential diagnosis is important for every case, and we discussed definitely our provisional diagnosis was the thoracolumbar burst fracture, but simultaneously the differential diagnosis and with the thoracolumbar burst fracture provisional diagnosis most commonly occur in the setting of the trauma. Patient with the following disease may be at the increased risk for the burst fracture with minor trauma such as the neoplastic infiltration, osteomyelitis, degenerative changes, osteoporosis. So these are the differential diagnosis here with us, and I want to present here I did the CT scan for him, and the imaging is consistent with the traumatic L2 burst fracture after a fall from height, and a CT scan with the 12 L2 burst fracture shows there is a STIR MRI of the same fracture and shows the post-operative reconstruction with anterior cage placement and pedicle screw instrumentation. Further workup, I did for this patient, and the laboratory workup such as the routine labs, imaging, MRI of the thoracolumbar spine to assess for the ligamentous injury, CT imaging to assess the bony anatomy and to aid in potential operative planning such as the flexion, extension. Film may be useful in select cases or at follow-up. As you know, the pathophysiology here, definitely trauma, but how most burst fracture occur at the thoracolumbar junction and are generally considered unstable injuries, and these fractures are the result of the axial loading force with the variable degree of flexion force vector. They are one of the most common traumatic injuries seen in the spine and occur predominantly after motor vehicle accident or fall from significant height. Burst fracture may occur more easily in pathological condition of the spine, such as in patients with the metastatic disease or in those with osteoporosis. The axial loading force results in failure of the anterior and the middle column of the spine, and the vertebral body splices out, and frequently the posterior wall of the vertebral body extruded into the spinal canal. On anterior-posterior bone imaging of the pedicle will often appear more widely separated and compared with the adjacent uninjured levels, and the neurological injury depend upon the level fractured and the degree of the canal compromise. Fracture near the conus medullaris may have the odd combination of the bowel and the bladder incontinence with normal lower extremity strength. At conus medullaris syndrome can happen. Mid to low lumbar burst fracture with significant retropulsion may cause quadra equina syndrome and the radicular symptoms secondary to the nerve root impingement from the hematoma, or a traumatic disc may also present, which should be distinguished from more severe injury pattern. Treatment options, we have the treatment option depend upon the level of injury, degree of the of the canal compromise, neurological status, deformity, and the treatment option include conservative management with bracing and or surgical reconstruction with anterior, posterior, lateral, and staged approach. Decompression may be included if indicated. The most common surgical treatment remains posterior pedicle screw instrumentation and fusion with the reduction of the fracture with correction of deformity, and the some fracture may require anterior column reconstruction with corpectomy and cage placement to achieve anterior decompression and to provide anterior and middle column support. Conservative management is a consideration for the patient without neurological injury, and in those with the mild comminuted fracture without significant deformity, external immobilization such as the thoracolumbar orthosis, surgical management is indicated for those with significant kyphotic deformity and the ligamentous injury or the neurological compromise. Posterior approach, the pedicle screw placement with the reduction and correction of the deformity, posterior fusion with allograft, decompression of the neural element is indicated, and corpectomy with the cage placement via posterior approach may be considered as indicated. And the lateral approach, lateral lumbar approach with the decompression and the reconstruction, corpectomy with the cage placement can be performed and considered. Supplementing construct with the posterior instrumentation. Anterior or anterolateral approach with corpectomy and reconstruction allow anterior decompression and reconstruction. Consider supplementing construct with the posterior instrumentation. Here I want to add a little thing for this lecture regarding this problem. As you know, the spine roll in the axial load. This spine rolls in the axial load bearing with the multidimensional range of the motion make it susceptible to various mechanisms of injury. Burst fracture related to the axial load traumatic kinetics are one of the possible outcome, and the other being impaction fracture and the split fracture as seen in the AO spine thoracolumbar spine injury classification system. As you know, the burst fracture occur most commonly in high energy trauma scenarios such as the high altitude falls and the motor vehicle accident based on the 3-column model. The burst fracture results because of the mechanical failure of the anterior and the middle column while under construction. So it is very important to understand all the mechanics here, but simultaneously, as you know, the thoracolumbar region of the spine is the most common site, and the most frequent clinical presentation are back pain and decreased height and height shortening, restrict range of the motion, and the focal sensory or motor neurological deficit. The importance of increasing our understanding and of elucidating the optimal treatment of the burst fracture are highlighted by the fact that the compression fracture are the most common type of the traumatic spine fracture, as well as the negative impact of the spine lesion on the patient quality of life and functionality. The decision on whether to treat burst fracture surgically or conservatively, especially when patients do not have a neurological deficit, is complicated, although conservative treatment has shown comparable outcome with the surgical approach in several studies. Not all patients have shown an improvement. Predictors of the failure of the conservative treatment have been studied, and the greater age and the interpedicular distance are the most distinguished. When surgical treatment is preferred, the optimal selection for an approach remains unclear, as both procedure anterior and posterior have reported advantages and the disadvantages, and the recent studies have shown no difference among various outcomes. The factors such as fracture type, stability, degree of the canal encroachment, and the neurological status should be studied to determine the ideal type of surgery. This study aims to evaluate and analyze all the available evidence on the various clinical parameters by a systemic review to determine the actual advantage and the disadvantage associated with the technique and provide summary. So actually, and I want to present this lecture in that regard, that that we have something we can say here, but we want to be something which is very much concrete. As you know, for the concrete thing, we should have the certain and subtle, and the subtle means we can say the knowledge, so we can discuss among each other. The operative outcome analyze include the intraoperative time and the bleeding volume, include the technique, and everything. It is very, very important. And the operative time and regarding it is very, very important, and some meta-analysis of different data, they are suggestive for that. If your operative time is reduced, your bleeding is reduced, and once your bleeding is reduced, definitely the patient's recovery is better as compared to the routine case. So in that regard, as I mentioned here, that regarding our case, so the surgical technique is very important, and I want to discuss the surgical technique with you. For posterior approach, the patient is positioned prone on a Jackson table. A Jackson table helps facilitate normal anatomical alignment, and the thoracolumbar spine is then prepared and draped in a sterile fashion. A lateral fluoroscopic film is taken and the appropriate level is located. An incision is then centered in the midline and extended to include the proposed level to be fused. The lamina, the facet joint, and the transfer process are exposed with electrocautery, and the pedicle screw are placed at the level above and the below the fracture vertebra. And my practice is that I am putting 4 screws above and 4 screws below in a normal vertebra, because it's helping me to, and I got the results in like that, because I am very much certain about that the implant failure is very less, and malfunctioning of the implant is very less when you are putting 4 screws above the problem and 4 screws below the problem. Definitely this patient is a burst trauma, but even though in the TB spine, when I operated 4 above 4 below, simultaneously if there is some trauma or some maybe some, for example, if a localized osteomyelitis, and when you are doing the corpectomy for the neoplastic reasons or maybe traumatic reasons or any other reason, definitely it is helping too much. And when you are putting 4 above 4 below, and it is a very, very, this is my humble explanation and experience, but the pedicle screw are placed at the level above and the below. I am putting 4 screws above, 4 screws below, and the reduction screw along with the decompression or the osteotomies may be necessary to achieve reduction of the fracture and correction of the deformity and allow for the decompression. Sometimes if deformity with the osteotomy, pedicle subtraction you can achieve, you should achieve. But sometimes if you cannot, then you should compromise over deformity, but don't compromise over the neurological deficit. So don't overdo, do which is required or which you can do safely and swiftly. So decompression of the neural element, and if corpectomy is planned, the discectomies are performed above and the below fracture body. Rongers, curates, high-speed drills are used to complete the corpectomy and decompress the neural element. The anterior and the middle columns are reconstruct using as an expandable interbody device combined with auto and or allograft, and the posterior lateral bone surface are decorticated and the bone graft is placed over the decorticated area to the augment bony fusion. And for the lateral approach, the patient is placed in the decubitus position, and the lateral and fluoroscopy is used to locate the fracture level. An incision is made in the flank overlying the fracture fragment at the L1 and T12 level, and it is usually necessary to remove a portion of a rib to gain access to the spine. After blunt finger dissection, serial dilator are placed through the psoas muscle. A self-retaining retractor is then introduced for mid to low lumbar injuries, and the neuromonitoring potential should be used to ensure there is a no compression of the femoral nerve. Such lies adjacent to the psoas muscle, and discectomies or the corpectomies are performed as indicated. After adequate decompression, an interbody device is placed. If supplementation with the posterior instrument is planned, the patient is turned into the prone position on a Jackson table. As you know, there the retroperitoneal dissection is an option. The peritoneal and its content are swept anteriorly by a blunt dissection, and you can do with the finger, but the gentle palpate it. If you have a good learning curve, you know that definitely, because I have multiple time experience this thing, and I done multiple retroperitoneal dissections for the lateral approach, and it is sometime helping you. And don't too much try cut the psoas muscle. Just try to split the psoas muscle and achieve where you have to put the screws. Yeah, definitely where the area is fractured and need the proper decompression corpectomy, definitely you have to do, but try to split rather than cutting. And this is, in my experience, it is a very good, and make a window. From that window you can approach, you curate and rongerize or drill whatever you can do, and you can apply locally there the self-retaining retractor, and you can manipulate accordingly, and then you can manage, I think, very, very appropriately. And once you get that, then you can put the cage of your choice. And the corpectomy, removal the vertebra between the removed disc, and rongers and the drills and the cutting burrs may be used, and the cancellous bone can be bleed profusely in contrast to the cortical bone, and you know that the hemostasis can be maintained by timely resection of the cancellous bone and cut to the cortical bone. And gel foam you can apply, bone wax you should apply, and definitely once if you apply little more bone wax, no problem, just check it and then you can remove, and then it suits you, means if you want to remove from that part, then you remove from that part, and if it rebleed, just cover it with that bone wax. So you know that, and it will help you. Okay, once if you put anything more, then you can remove, and means meticulously, and you can decrease the load of the foreign body as much as possible. Here I just want to mention one more thing. An intact anterior longitudinal ligament and the anterior and the contralateral cortex help protect great vessels. So don't go far beyond, just achieve your target. Don't try to be more drawing there, don't try to be more artistic there, rather than see where you decompress well. Once you decompress well, then you can apply the things appropriately, accordingly. Because the decompressing the spinal canal is our choice of action, and the instrumentation anterior reconstruction generally include an interbody cage, autograft or allograft, or the anterior and the middle column support along with the plate or the rod affixed to the adjacent vertebra body, and to limit motion at the fusion site. And the specific technique or the instrumentation varies varies by manufacturer. General considerations are listed subsequently and refer to the manufacturer guidelines for the detail of each device. As you know, the complication avoidance and the management is very important in these cases. Post-operative imaging with the CT is essential to assess bony anatomy before instrumented fusion, and the patient managed non-operatively should be followed closely in a clinic with the lateral films to ensure to progress of the deformity and the deformity development. Intraoperative neuromonitoring may alert the surgeon to change in neurological status, and the stimulation of the pedicle screw aids in accurate placement. Significant blood loss, especially with the concomitant corpectomy, should be expected and communicated to the anesthesia team before incision. Intraoperative fluoroscopy and the navigation to assist in the placement of the instrument, it is very important. And the compression fractures such as the burst fracture are the most frequent type of traumatic spine fracture, and the burst fracture can be managed through anterior, posterior, and the combination of both approach. A better understanding of the potential benefit of the surgical against conservative treatment, and subsequently the strength and the shortcomings of the anterior and posterior approach should aid in the selection of the most favorable treatment of each patient, which is important for the burst fracture have a detrimental impact on the patient's quality of life even after undergoing surgical treatment. Several studies you read maybe, but definitely you know that comparing the conservative and the surgical treatment of the burst fracture without neurological deficit, nevertheless the decision to operate and not remain controversial in as much as overall both approach have been shown comparable outcome, and it is worth restating that the greater age and the interpedicular distance seems to be the predictor of the failure of conservative treatment. So, as you know, advocate of the anterior approach argue that there is a technique offer advantage such as the possibility of the better window for the spinal canal decompression. Conversely, the posterior approach has demonstrated benefits such as the shorter operative time, less blood loss. Ultimately, when selecting the operative approach for the patient, the surgeon must consider various factors before making a decision, including the surgeon experience, fracture type, neurological status, medullary canal compromise degree, and among others. So, and as you know, I have thank God I have a good experience that I can do posterior and anterior, and I did multiple even though I was under training of the spinal surgery. But you know that both have our advantage and the disadvantage. But my advice, even though is that if you can manage anything posteriorly, go posteriorly, because it is less morbid as compared to the anterior. And few people are telling no, it's a very, and it is like little heroic. Definitely when I was doing, I was feeling that it is heroic. But definitely you should know that because the surgery you are doing over the patient, not upon you. So I think you should think about the patient first rather than you think just to satisfy your own ego. I can do that, or in my opinion you should do whatever the best for the patient, and if you are achieving the goals posteriorly, should try posteriorly. If you cannot achieve, then you can combine approach, definitely only anterior approach, only give the lateral we can say the fixation, and which definitely it is not correcting the definitely deformity, but yes, placement of the cage from the anterior is more safer and easier and neurologically more stable and satisfying as compared to the posterior. So definitely then I will go not only for anterior, then I will go for the means combined approach. Why combined approach? Because with the placement of the cage you can put from anterior, but definitely when you are putting the screws and transpediculatives from the behind, from the posterior, is better. This, and you know there are some limitation for every case, and as you know the limitation of the case, then definitely you can justice with that. Surgical intervention is usually selected to rehabilitate patient with the burst fracture, and the data obtained in different studies in the posterior approach represent a viable alternative to an anterior approach when comparing outcome in a short-term post-operative period. Various advantages such as the shorter operative time and decreased bleeding were identified posteriorly, but further evidence is needed for the accurately defining the indication for each approach, and the decision for which surgical approach is selected should be an individualized process, and taking in account surgical expertise and the resource available what we have. I think it's enough for this topic, and we will meet in one more topic after that. Thank you so much. Please share it, like it, and subscribe me. Thank you so much.